Now we'll move on to our next speaker. We have Professor Abhidha Shah. Professor Abhidha is one of the biggest supporters of the Yemeni Research Society scientific programs, and she already gave many webinars and many presentations, and we all enjoy her presentations. Today, Professor Abhidha will talk about the anatomy of the hippocampal formation. Dr. Abhidha?
Thank you, Ahmad. Thank you for this invitation. And I have extended the topic a little bit to include the hippocampus, little bit of the limbic system, and some approaches for mesial temporal surgery, because the hippocampus is too small a topic, or it is sometimes too vast, but it is too much detail to talk about the hippocampus. But this is the structure that we are going to discuss today. And you can see the beautiful hippocampus. It is called hippocampus because hippocampus means seahorse. So when you look at it in an upturned fashion, the hippocampus resembles a seahorse. So this is the face of the seahorse. So that is why it is called hippocampus. And it is divided into this head, body, and tail. And the tail continues as the fornix, and it becomes the columns of the fornix. And then it goes on to end in the mammillary body. So this is the structure. Now the hippocampus actually consists of the hippocampal formation, which consists of this proper hippocampus or Ammon's horn. It consists of the dentate gyrus, which I will show you, and the subiculum. So these three structures comprise of the hippocampal formation. And the hippocampal formation is laid down in the hippocampal fissure. Now let us see what all these structures are. So both the hippocampi of both the sides, they come together here, where the crura of the fornix meet here, and then there is a commissure here in the midline, that is the hippocampal commissure or the saltarium. It lies just beneath the body and the splenium of the corpus callosum. It is sometimes very close to the undersurface of the corpus callosum, and you cannot dissect it separately sometimes, but this is the region where the hippocampal commissure is there, and it transmits information between both the fornices. Now, if you see the location of the hippocampus, it lies in the floor of the temporal horn. Here you can see that this is the temporal horn, and the hippocampus will lie here in the floor of the hippocampal, of the temporal horn. So this structure here on the medial aspect is the parahippocampus. So the parahippocampus, now just be with me here. Parahippocampal gyrus, it turns laterally and it forms a ledge. Now this ledge is the subiculum. The subiculum in Latin, it means support. Now over this subiculum, the hippocampal formation rises, and it is in the hippocampal fissure. So this whole structure here, so the parahippocampus will turn into the subiculum, which again turns to form the hippocampal formation, and again more medial to that will be the dentate gyrus. So we'll see these structures one by one. This is just to give you an overview. So if you look from a lateral aspect, this is the lateral ventricle, and you see the hippocampus, it is lying in the floor of the temporal horn, and here this is the choroid plexus in the choroid fissure. And the choroid fissure is a fissure that runs between the thalamus and the hippocampus and the fornix. So this C-shaped structure here is the choroid fissure, which runs here from the inferior choroidal point all the way back to the foramen of Monro. So where the anterior choroidal artery enters into the temporal horn, that is the inferior choroidal point, and the choroid plexus will run all the way here from in the choroid fissure and go to end in the interventricular foramen of Monro. So these are some important boundaries. So this is the choroid fissure. The hippocampal fissure lies just beneath the choroid fissure, and it lies between the parahippocampal gyrus, the subiculum, and the dentate gyrus. So that is where the hippocampal formation comes into picture. Now this is again a cut image that shows this gray matter of the hippocampus. And here you see it is closely related to this structure. I believe this is the topic of your next webinar, but I'll just show you this. This is the amygdala. So where the hippocampus lies in the floor of the temporal horn, the amygdala lies in the roof of the temporal horn. And you see that the hippocampus has a very distinct margin here to distinguish. The amygdala merges superiorly with the basal ganglia, more accurately with the globus pallidus. So this margin of your resection is important. You cannot do the dissection for epilepsy surgery here, you will enter into the globus pallidus. It has to be in this line. So you just take the amygdala and then take the part in the temporal horn and the mesial temporal structures. So this is again another image showing you the hippocampus. Here the temporal horn has been removed. This structure here is the amygdala, and the amygdala goes on to merge with the basal ganglia. So this is the basic anatomy of the hippocampus. Now let's go to the embryology. So earlier, when, in lower mammals, in lower animals, there was a spinal cord, there was a brain stem, and there was some corpus striatum on this. Later on, as evolution occurred, first the olfactory system developed. So this basically the olfactory system developed to get a sense of smell. That was the main sense of the organism, and that would alert the organism to danger. That's why these lower animals have very long olfactory nerves, because the sense of smell is their main sense, just like vision and hearing is the important senses for us. For them, the sense of smell is the most important one. For us, what happened around the brainstem and on the head, the thalamus is the head of the brainstem, and on the lateral and medial aspects of this developed two structures. On the medial side developed the hippocampus, and on the lateral side developed the olfactory or the pyriform cortex. So this was the primitive cortex, which was also called allocortex, with 3 layers. And these two structures are the limbic structures, the primitive limbic structures. So the archicortex was the amygdala and the hippocampus, which were medial to the thalamus. And the lateral part was the olfactory or the pyriform cortex or the paleocortex. Now, surrounding this 3-layered cortex, there developed a cortical ring that consisted of the parahippocampal gyrus, the cingulate gyrus, and the insula. This ring is the paralimbic structures and the insula, and it consists of 6 layers, but it is mesocortex. And around this developed the neocortex or the isocortex, where you have all the parainsular structures and the neocortex. So this is what I said. This is the brainstem. This is the thalamus, which is actually the head of the brainstem. And medial to this here developed the hippocampus and the amygdala, and lateral here developed the olfactory cortex. Now, as evolution occurred, this whole turning of the hemisphere occurred. So the structure that was here, the hippocampus that was here, got dragged all the way down into the temporal lobe, following this C-shaped formation. So from here, the hippocampus turned all the way down here to come to lie in the temporal horn. So it formed a whole C-shaped structure. So this is what happened to the hippocampus. So it came from here down and went all the way to the temporal horn. Now, in the superior part of this hippocampal formation, there were the corpus callosum developed. So the fibers of the corpus callosum actually invaded this hippocampal formation, and it became very small in this region. So this part of the hippocampus developed more, this part of the hippocampus developed less. So there are some remnants of the hippocampus which lie above the corpus callosum, and this we know as the inducium griseum and the medial and lateral longitudinal striae of Lancisi. So they actually come here, run from here, consist of the continuation of part of the hippocampus and the dentate gyrus, go here as the supracallosal remnant, as the inducium griseum, and come to end here in the paraterminal gyrus, in the subcallosal region. So this is a limbic circuit. Just like you have the Pspez circuit, this is the supracallosal limbic circuit. And there are other limbic circuits which we will not discuss in detail, but I will just show you. The Pspez circuit we are going to see today. This is the dorsal amygdalofugal pathway that consists of the stria terminalis. This is the ventral amygdalofugal pathway, where it connects to the temporal stem to the olfactory region. Then, of course, the Pspez circuit, and then the supracallosal circuit. So the limbic system, this whole core developed at the edge on the medial aspect of the hemisphere, and that's why it is called as limbic. Limbic means border or margin. And all this I will show you on the medial aspect. The whole system is the limbic system. So it was actually first referred to as the limbus, then Broca called it Le Grand Lobe Limbic, MacLean called the cortical, subcortical, and all the fiber connections the limbic system, and Notta extended the limbic system to include the midbrain. So basically, Pspez postulated that the anatomical basis of emotion was found in the hypothalamus, in the anterior thalamic nuclei, in the cingulate gyrus, hippocampus, and its interconnections. And this is very true, as we will see today in the Pspez circuit. For those who are interested in more information, can read this. So these are all the components of the limbic system. So the most important one is this hippocampal formation. Then you have the amygdala, the hypothalamus, the nucleus accumbens, the cingulate cortex, areas of prefrontal cortex, and nuclei of midbrain. And the fibers that are involved in this are the cingulum, the longitudinal striae going above the corpus callosum, the fornix, the anterior commissure, the mammillothalamic and mammilotegmental tract, the stria terminalis, the dorsal longitudinal fasciculus, and the medial forebrain bundle. So these are the whole components of the limbic system. We are just going to concentrate on this hippocampus for today. So I will show you this now in dissection, how the hippocampus looks when you come from medially, how it looks when you come from laterally, and how it looks when you come from inferiorly. So this is coming from medially. So this is the corpus callosum. We know this structure very well. As I told you, on the superior aspect of the corpus callosum, there is the thin remnant of the hippocampus, or the inducium griseum. It's a very thin layer of gray matter. And within it, you see this white structure that is running. That is the lateral and medial longitudinal striae of Lancisi. So this is the supracallosal circuit. Here you can see the striae more nicely. Here you can see the longitudinal striae that are running on the surface of the corpus callosum. Now coming to the limbic, to the medial aspect, the next important structure is the gyri that are involved in the limbic lobe. And the first one here is the cingulate gyrus. So this is the one that is lying above the corpus callosum. And there is another interesting thing. These sulci that you see here, this subcallosal sulcus, this cingulate sulcus, the subparietal sulcus, the anterior part of the calcarine sulcus, this whole thing is also known as the limbic fissure. So just beneath the limbic fissure, you have the cingulate gyrus, which continues down here as the parahippocampal gyrus. The parahippocampal gyrus is also connected to the lingual gyrus by this offshoot. So both these gyrus together continue as the parahippocampal gyrus. So on the medial aspect of the hemisphere, here I told you that this is the beginning of the choroid fissure. This is the interventricular foramen of Monro. This is the fornix, this is the thalamus, and this choroid fissure runs all the way between the fornix and the thalamus to form the choroid fissure. Now, when we dissect more medially, so this, when you come from medial, so the first thing that you see here is the parahippocampal gyrus. Beneath the parahippocampal gyrus, you trace these fibers and you will see this. There are fibers that end here. This is the radiation of the cingulum. So cingulum begins here in the subcallosal region, goes superiorly and comes to end here as the radiation of the cingulum. Some fibers also connect to the cortex as cortical connections of the cingulum. This is important to understand how emotion gets converted to higher cortical centers. So coming back here, this is the mammillary body. So the fornix ending here in the mammillary body, and it is continuing as the mammillothalamic tract to end in the anterior nucleus of thalamus. So I am simultaneously dissecting the medial aspect of the temporal lobe and also of the ventricle, the thalamus and hypothalamic region. So here you see this, if curve the specimen, you can see the anterior nucleus of thalamus. You see another tract that is going down here. That is the mammilotegmental tract, which goes all the way down to the midbrain. Now here you can see within the ventricle, the septum has been removed and you can see the caudate head. So now you see how this radiation of the cingulum is coming here. Now this region here is the uncus, or the region of the amygdala in the hippocampus. So the anterior part of the uncus is the amygdala. The posterior part of the uncus is the hippocampus. We'll see this more better when you see from the inferior aspect of the brain. So then again here, this region here, that's this structure that you see here is the anterior commissure. This is the mammillary body. This is the mammillothalamic tract, and here this is the columns of fornix. Now here you can again see the anterior thalamic nucleus very nicely. Now here we have gone further. Now I've deflected this radiation of the cingulum down, and you see the whole structures of the hippocampal formation. So this is the proper hippocampus, or the Ammon's horn. Here you see this denticulate structure. This is the dentate gyrus. So this sulcus that separates this fimbria and the dentate gyrus is the fimbrio-dentate sulcus. The fimbria begins as a band of fibers on the surface of the hippocampus. They start as the alveus. Alveus means a band. And the alveus continues here as the fimbria, which goes up and continues as the fornix. So this is the beginning of the efferent pathway of the hippocampus. So the fornix is the main efferent pathway of the hippocampus, and this is how it begins here with the alveus and the fimbria. So this is the dentate gyrus. As I showed you, see, parts of the hippocampus and the dentate gyrus go here above the callosum, and this is the inducium and continue here as the inducium griseum. Now going further, the dentate gyrus has been removed, and now you can see the whole hippocampal head. You can see the fimbria going on to become the fornix. And this region that you see here, this fissure between the thalamus and the fornix, is the choroidal fissure. Now going further, now I've cut the corpus callosum here, and you see this body of the caudate head lying in the floor of the lateral ventricle. So once I lift this caudate head, you see fibers that are running beneath the caudate head, and these are fibers of the anterior thalamic radiation. So here you can see this is the anterior thalamic peduncle or the anterior thalamic radiation, and they go on to end here in the region of the cingulum. Now you can see that this whole structure is now the Pspez circuit. So it begins here in the hippocampus, becomes the fimbria, the fornix, the body of the crura, body of the fornix, the columns of the fornix, the mammillary body, the mammillothalamic tract, the anterior nucleus of thalamus, the anterior thalamic radiations coming here to end in the cingulum, which turns back here in the radiation of the cingulum and ends here in this entorhinal cortex or in the region of the hippocampus. And this whole completes the circuit, which we all know is the Pspez circuit. And this is the Pspez circuit that has been dissected outside after delineating it on the medial aspect of the hemisphere. So now we saw the hippocampus from a medial aspect. Now let's come inferior. Now inferiorly, this region is the parahippocampal gyrus. You see it turns anteriorly into this rounded structure, which we all know is the uncus. The uncus is very closely related to the cerebral peduncle. So there are two cisterns here, the crural cistern and the ambient cistern. And there are some important vascular structures that run in this cistern, which we all know. So now again, you see this structure. This is the parahippocampal gyrus continuing here from the cingulate. It turns ahead anteriorly to form this region that is the uncus. This sulcus that is here, separating the parahippocampal gyrus from the collateral, from the fusiform gyrus, is the collateral sulcus. And the most anterior part of the collateral sulcus here. So this sulcus that you see here is the rhinal sulcus. And the rhinal sulcus is the second sulcus to appear phylogenetically. The first sulcus to appear is the hippocampal sulcus that is between the subiculum and the hippocampus. So you see this rhinal sulcus separates this cortex from the neocortex. So it separates this uncal region from the temporal pole. And this is this is the second sulcus to appear in the human brain. Now here you see how closely related the uncus is to the cerebral peduncle. And here you see the uncus with the relation of the posterior cerebral artery here in the crural cistern, how closely they are related, and we all know the significance of this uncal herniation. Now, another important thing of this uncal region is this anterior part. So it can be divided into an anterior segment and a posterior segment. So the anterior segment of the uncus is the amygdala, and the posterior segment of the uncus is the head of the hippocampus. Now let's see that in images. So now this is the inferior aspect here. You see the cerebral peduncle. So I've removed the gray matter of the parahippocampus. So the first structure that you see is some fibers that are ending here, and that is the radiation of the cingulum. This is the region of the uncus where you can see that some gray matter has been removed. These are fibers that are just at the ependime of the temporal horn, where the radiation of the cingulum is ending to come in contact with the entorhinal cortex. Now, once I lift this, I see the ependyma of the temporal horn. Now, you can also see simultaneously I'm removing gray matter of the uncus also here. Now, when I lift this ependyma, what do I see? So now imagine that there was the uncus here. As I told you, this is the anterior segment and this is the posterior segment. So the anterior segment directly leads to the amygdala. The posterior segment leads to the head of the hippocampus. So this is the region of the uncus. And this is how it looks from an inferior aspect. So this is the hippocampus, the head, and the body. Now in this region, you can appreciate this pes hippocampi. You see, the paw-like structure that we called. This is called the pes hippocampi. This is the choroid plexus in the choroid fissure. And these fibers are actually fibers of the Meyer's loop, as we will see now. So now when I deflect this hippocampus, remove it downwards, you see this structure here. This is the region of the lateral geniculate body in this region. So the part of the thalamus, from here fibers arise You see these fibers that arise and they curve laterally to go in the roof of the temporal horn in the anterior aspect and in the lateral wall of the temporal horn in the posterior aspect. And this fiber bundle is the Mayer's loop. So you can see the optic tract coming here and ending in the lateral geniculate body. Now you can see this Mayer's loop more nicely in this image, originating here from the lateral geniculate body and going laterally. Now this Mayer's loop actually turns here, and on the lateral aspect of the hemisphere, you can see this more nicely as it continues as the optic radiations. Now, there are many approaches that have been described to reach the hippocampus. So this is important for us neurosurgeons. So we have described an approach to the temporal horn where it is safe. I will show you this approach. This is through the middle temporal gyrus. Some Yassergill described this trans-Sylvian approach to reach this region, but this is a little dangerous because the uncinate fasciculus comes in the way and may be at risk to injury. Then there is a supracerebellar approach that has been described to mesial temporal regions and an inferior temporal gyrus, so approach to the hippocampus. So a lot of these approaches have been described. The main important thing of these approaches is to avoid injury to the fiber bundles that come. So we saw the hippocampus from medially, we saw it from inferiorly. Now let's look what happens laterally. This is what is most important to us as surgeons because this is the view, this is the where we operate. So now the hippocampus lies when you start your incision in the middle temporal gyrus. So when you enter into the middle temporal gyrus, you will enter into the temporal horn, and then you will see this is how the hippocampus lies. So this is the head, the body, and the tail. This is the roof of the temporal horn. This is the floor of the temporal horn. And what are the fibers that will come? So on the lateral aspect, you will have the arcuate fasciculus, you'll have the middle longitudinal fasciculus, and more inferiorly is the inferior longitudinal fasciculus. Now, these are just some things that you should remember. This will not come in the way when you're going into the hippocampus, unless you are really going in some other trajectory. The IFOF will come in the way, which I will show you. So this is the arcuate fasciculus. This is the SLF. This is the IFOF. This is the uncinate fasciculus. And down here is the inferior longitudinal fasciculus. This might be in the way when you're operating in this region because it comes in the region of the inferior temporal gyrus. So this is the IFOF as it is running here. And this whole bundle here is the sagittal stratum, which is consisting of the IFOF, the anterior commissure fibers, the optic radiations, and the tapetum. And this whole block is important. This is not the topic for today. Now, this is the approach that we have described. So now you look at this IFOF. In the anterior aspect of the temporal horn, this IFOF is in the roof. And in the posterior aspect of the temporal horn, the IFOF is in the lateral wall. Both, this is the combination of the IFOF and the optic radiations. So in this anterior aspect, this is the head of the hippocampus in the temporal horn. So in this anterior aspect, there are no fiber bundles. So this is a very safe region to enter for epilepsy surgery, for approaching mesial temporal structures, for parahippocampal region lesions. You can safely enter from here and then carry on your resection without having any damage to the Mayer's loop and to the IFOF. So here you can see in another diagrammatic representation, this is the roof. You can see this area where I put the pinhead is safe of any fibers. It is only laterally that these fibers are come. So when you enter here and you remain beneath the roof of the temporal horn, you're relatively safe and will avoid injury. So we described this approach. Professor Goel described this approach for epilepsy surgery. We started using this middle temporal gyrus and we started entering from this anterior aspect and then removed this whole region. So we enter the middle temporal gyrus, reach the temporal horn, disconnect the amygdala here in the roof, remain beneath the roof, and disconnect this whole structure in an en bloc fashion. And this was our amygdalo-hippocampectomy combined with a temporal neocortex resection. And you can read this paper on our subject. So now coming back here to the choroid fissure. So this again, we are seeing the hippocampus. I keep coming back to the choroid fissure because this is an avenue here. When you enter the choroid fissure from here, you will go into the ambient cistern. When you enter here in the region of the atrium, you have avenue straight to the quadrigeminal cistern. And here in the lateral ventricle, when you enter, you have avenue to and you can enter into the third ventricle. So it is a very important fissure. You can see this star that I made, and that is the choroid fissure between the hippocampus and between the thalamus. Now a view from the top is the same choroid fissure that is running. This is the central core of the brain, which is bordered laterally by the insula, and medially it reaches the ventricle. So the central core is insulated between the ventricles on one side and the insula on the other side, so that it is safe inside. So these are the various limbic connections, which we will not discuss today, but you can see that I showed you a supracallosal circuit, then there is the Pspez circuit, then there is a dorsal amygdalofugal pathway, and then there is one on the ventral surface, that is the ventral amygdalofugal pathway. And this actually model depicts all these limbic structures in detail. Now, just coming lastly to the approaches. So when you understand this anatomy, you realize that there are beautiful avenues to reach the brain. So to reach this cistern, suprasellar and the ambient cistern, we described for the first time a lateral supracerebellar approach. So this middle fossa, this epidermoid tumor is entirely in the middle fossa. And we went from posterior fossa up and removed this tumor and this epidermoid in the cistern and in the medial temporal region. Then you see this tumor is a huge glioma in the region of the parahippocampal gyrus. You can see the tractographic images. All the fiber tracts are displayed superiorly. So it is safe to enter from this region, enter into the temporal horn, and enter into the tumor in the region of the parahippocampal gyrus. And here you see the tumor and you see the radical resection. We have used this middle temporal gyrus approach to reach this. This is again another low-grade glioma exactly in the region of the parahippocampal gyrus. So here you see this is the region of the uncus. Here you have the hippocampus, and here you have the parahippocampal gyrus. Again, you can come from this trajectory. It is safe. You can come from the inferior temporal gyrus. The only fiber bundle here, which you see here, I've mentioned, is the ILF, the inferior longitudinal fasciculus. This red thing is the tumor. You enter from here. The tract is above. You can go in and perform a beautiful radical resection without causing any harm to the patient. Now, this is a proper mesial temporal tumor involving the hippocampus, the amygdala, and the parahippocampal gyrus. So you can see the trajectory, a middle temporal gyrus approach, go enter into the temporal horn, go medially, and remove all the structures. Now, this is a beautiful low-grade tumor here. So you see, this is the amygdala, and a part mainly in the amygdala, this tumor. So this is the location of the tumor. Again, you can see the trajectory. It is entering from a middle temporal gyrus approach. You enter into the temporal horn, you identify the roof of the temporal horn and the floor of the temporal horn and remove the tumor. Now, this tumor is involving both the amygdala, the hippocampus, and the region of the parahippocampal gyrus. You can see this structure. You can imagine with this anatomy, this image here, and exactly you can make out where the tumor is. You enter from the middle temporal gyrus using this cortical incision. And of course, here we've gone radically and done a good radical resection of the tumor along with the adjoining cortex, and the patient has done well. So there are some other tumors. So this is a tumor in the choroid fissure. So I was telling you the anatomy of the choroid fissure. So the choroid fissure is between the thalamus and the fornix, and this is an epidermoid tumor that was actually coming into the choroid fissure. Again, this middle temporal gyrus approach, you enter into the temporal horn, enter into the choroid fissure, and you can remove the tumor without causing any problem. Again, another beautiful tumor in the parahippocampal gyrus extending into the region of the temporal horn. So the trajectory is very simple. You come here from the anterior aspect so that you do not damage the fibers in the posterior aspect of the temporal horn, and you enter into the tumor and you see the radical resection. So lastly, there are some connections between the limbic system, between the telencephalon, diencephalon, mesencephalon. So this is the striatum medullaris. It is this structure. It runs from the septal nuclei here and goes all the way to the superior leaf of the pineal gland here, which is the habenular commissure. So this structure here is the striatum medullaris thalami. The fasciculus retroflexus is from the habenular nuclei to the midbrain, so going all the way from the habenular commissure down. And this is the medial forebrain bundle from the septal and lateral preoptic region going to the midbrain tegmentum. So that is the limbic system and some parts of the hippocampus that I've just shown you today. And I hope you have enjoyed my lecture. Thank you very much.
Thank you very much,
Thank-
Professor. Dr. Khalid, please your comment.
Thank you. Thank you. Very interesting lecture. Thank you for all. Thank you, Dr. Ahmad. Thank you for all for speakers, and thanks for all colleagues. No, any comment?
Thank you, Professor Abhidha. It's a very nice lecture and very enjoyable as always. We always you have shown us very nice dissections and very nice pictures. So thank you for this very nice and thorough presentation. I will see if there is any question from the chat. Also, that everything was very clear, but let's see if anyone have any question or any comment. Okay. Let's see here any questions. Okay. Dr. Abhidha, I have one question, please.
Yes.
You show in some of the cases that you show, you do resection of the part of the temporal lobe for the amygdala and the hippocampus. In case of this lesion in the dominant hemisphere, what is the safe boundaries that you do during operation to not to affect the language and the critical areas?
So there are two things. You have to preserve the cortex. So the cortical area that is eloquent is in the posterior part of the superior temporal gyrus. So on the dominant side, on either side, you're not going to the superior temporal gyrus. I'm always in the middle temporal gyrus and below. I'm not causing the superior temporal sulcus at all, ever. So my cortical area is safe. The second landmark is I'm entering into the anterior aspect of the temporal horn, and then I remain beneath the roof. I never violate the roof of the temporal horn. So that keeps the IFOF safe. So that is how you preserve language. You remain beneath the reef of the temporal horn and you remain beneath the superior temporal sulcus. Then you will not have a problem.
Thank you very much. Okay. Dr. Khalid, do you have any comments or any question for Professor Abhidha Shah?
No, but I enjoy with the answer of Dr. Shah. Frontal for center of speech, it is really temporal is opposite for frontal. Frontal is middle gyrus. Frontal gyrus is dangerous. Superior is better. Temporal middle is better and superior is dangerous. This is opposite for idea for Dr. Shah for speech.
Thank you very much.
Okay.
So I think by this we can conclude our seventh session of the Comprehensive Neuroanatomy Educational course. And so we see you all next week, inshallah, with more speakers and more presentations. And thank you, Dr. Khalid, for moderating this session. And congratulations again for your promotion to Professor of Neurosurgery in Hadramaut University. So, thank you, everyone, and
thank you.
See you all next week, inshallah. Thank you.
Thank you.